I was asked to talk about vesicoureteral reflux, and it is a complex and probably too difficult topic to spend a lot of time in detail. So what I was hoping to do is to give you an overview and give you some of my ideas about what the current situation in terms of evaluation and management of vesicoureteral reflux is. In terms of the, I'm trying to get the screen to advance. Okay. In terms of reflux, one should not forget the fact that it's a long history. Some people say that vesicoureteral reflux was the starting point for pediatric urology. But there's been a lot going on before pediatric urology became a subspecialty in its own in the 1960s. So you'll recall that very early on in antiquity, there was description of reflux in the fact that Galen described action of the uterovesical junction as a valve mechanism. The interesting thing is at the turn of the 1900s, Samson described infections going from the bladder up into the kidneys and certainly causing some kidney infections. And that was really the starting point for studies such as that of Kretschmer, which described cystography and demonstrating urine going from the bladder back up to the kidneys. And that was present in a significant number of children. In 1930, Meredith Gamble did a study which showed that about 12% of kids who were studied, and this was across the board, 12% of them had reflux, which of course is a little bit higher than one would expect at this point. We know that it's probably closer to 1%. In 1960, there was a clear association recognized between vesicoureteral reflux and chronic pyelonephritis. And this was, I think, the very, very important study. Noam Hodson described this, and then subsequently a number of surgical procedures described in the 50s and 60s to fix reflux. We know about Hutch, Paquin, Litch, Gregoire, Cohen, and other people like that who described new techniques. There was recognition of intrarenal reflux. Whether or not that's a true harbinger of kidney damage is not really clear, but intrarenal reflux was something that people starting to recognize using IVP. Later on in 1978, there was a very good book that was published by Hodson and Kincaid Smith describing the findings of reflux nephropathy and describing what was known to that point with regards to the effects of reflux on the kidneys. And then, as we all know, Philip Bransley described the Big Bang Theory in his animal model of piglets, which described the fact that when infection was in the bladder and reflux was caused artificially, the kidneys would also get infected. And then we can go on for a number of hours talking about the history of reflux. It's quite interesting, but we won't spend a lot of time. I think the most important factors that we should remember are the Birmingham study looking at reflux, the use of DMSA for renal imaging, which I think is a very important adjunct to our evaluation of the kidneys. And then, and we'll talk about this a little later on during the talk, in 1981, the International Grading System for Reflux was established. And then Pure and O'Donnell popularized a sting in Ireland in 1984. But I think most importantly are the newer studies that have come out. The AUA guidelines are based on those studies, as well as the newer studies from out of Sweden and out of the River study in the United States. These studies are very, very important in modifying the way we look at reflux at the present time. So what is vesicoureteral reflux? Is it a disease? Is it a symptom? Or is it just a condition? All by itself, reflux does not cause pain. It's completely silent. and only comes to our attention if the child develops a urinary tract infection or is noted on an ultrasound to have some degree of dilation either prenatally or postnatally. So in that regard, it is a completely silent condition. If you look at it a little more closely, it seems as though there is a genetic component, and so it is a familial condition. It's characterized by regurgitation of urine from the bladder back up into the upper urinary tract. And this is usually documented either by a VCUG, or voiding cystourethrogram, or radionuclide cystogram. Otherwise, it's very hard to document reflux. It can be associated with a spectrum of renal parenchymal lesions, and that's what we're mostly interested in, with or without a history of infection. We know that a number of little boys are born with high-grade reflux. They've never had an infection, and yet they have loss of function in the kidney where there is high-grade reflux. So in that regards, I think one should think about the various categories of reflux and not lump reflux as one single entity. I think it's important to look at reflux as different types of manifestation of the same thing, which is urine going up into the kidneys. I don't know what the numbers are in Egypt, but in the United States, about 25,000 patients are seen by urologists for vesicoureteral reflux. I'd be curious to know how often you actually do see reflux in your practice. Is this something that's very frequent? Is it something that's unusual? What's the prevalence in Egypt? Can you share that with me? You're muted. Okay, thank you. So here's the way I look at the various categories of vesicoureteral reflux. The first category that one should think about is the neonatal reflux, which is seen in general in a child who's been diagnosed prenatally with hydronephrosis. This is usually a male. The reflux tends to be of higher grade, and it tends to go away pretty quickly within the first 2 years of life. It is associated with a higher rate of renal lesions and may be part of CACUT, which is congenital anomalies of kidney and urinary tract. The second category that we should think about is the young girls with vesicoureteral reflux. And these are patients who come in with urinary tract infection. They usually are female. Their grade of reflux is a little bit lower. The resolution rate varies quite a great deal. Some of them have significant voiding dysfunction. And in these cases, the renal lesions are actually rare. Then there's sibling reflux, which used to be something that we would screen for, but we do not do anymore. These patients have lower rates of urinary tract infection. They have very rare lesions in the kidneys, and their spontaneous resolution is fairly high. They usually are of low-grade reflux. And then you have the more complicated type of reflux, which I think is the most interesting, and that's the reflux associated with duplex system or bladder diverticula, which also are probably part of the CACOT system. And then you have the very, very rare megacystis megaureter complex. But each one of these categories, I think, has to be looked at in a somewhat different manner. Of course, a young boy who comes in with high-grade reflux and is monitored will possibly outgrow the reflux and therefore may not need treatment. However, if he develops a urinary tract infection, then that may be a cause to treat the reflux. So if one looks at the genetics of reflux, we have so far not a lot of great deal information, but there are some new studies using Lincoln analysis, and we're doing this at Children's Hospital in Boston, looking at families with reflux, and it seems like we can actually try to determine some of the refluxes, some of the genetics using some markers such as uroplakin, SLIT2, ROBO2, TGF-beta, who may be associated with reflux. However, it's quite clear that there's a great deal of heterogeneity in the reflux. So far, only 12 genetic loci have been identified, and it may be that the different forms of reflux that we talked about may have different genetics determinant. I think it's going to be very important in the future to identify these genes or gene loci so that we can actually make a diagnosis, not so much on the basis of a VCUG, but rather on the basis of a chromosomal analysis. And that's where the future lies. I think the patients would appreciate it, as they all really love having a VCUG. There are some misconceptions about reflux that I must discuss with you all. One is, and we hear this from our patients and from some of the pediatricians who refer patients to us, urinary tract infections cause reflux. Well, we know that that really isn't the case. We know that some cases where there is a gram-negative infection, the gram-negative infection may be associated with release of endotoxin, and the endotoxin may modify the behavior of the smooth muscle of the bladder and of the ureter. But in general, urinary tract infection does not cause reflux. Reflux also does not cause urinary tract infection. It is the association of vesicoureteral reflux with UTIs that is of concern to us. There has been for a long time, and this is following the studies from the 60s, that reflux was a major cause of renal insufficiency. Well, that may be the case in patients who have bilateral high-grade reflux and a significant degree of renal dysplasia, and we'll talk about dysplasia a little later. But if you look at the numbers in the transplant clinics in the United States and in Europe and possibly in Egypt, right now, reflux is not seen to be a major cause of renal insufficiency. It's the rare case of the patient who's had recurrent pyelonephritis who may indeed end up with kidney dysfunction, but at this point, it's clear that it is not the major #1 cause of renal insufficiency in the pediatric population. Another misconception is that renal scarring is a direct consequence of reflux. While recurrent pyelonephritis can actually cause renal scarring, it is clear that a good number of these patients have renal lesions on a DMSA scan or an ultrasound, and they do not have any evidence of any prior urinary tract infection. And so it's very important to remember that renal scarring can be due to pyelonephritis, but in a lot of cases, it really is the result of renal maldevelopment early on during embryological development, and this is renal dysplasia. And we'll spend a little time talking about that also. Treating reflux will invariably prevent renal scarring and progression of scars. That has been shown by a number of studies to not be the case. You may reduce the incidence of renal scarring, but it's not always the case, and this is certainly something that we want to try to strive for. But again, we're not always successful, and I've had a number of patients who've been treated, had successful surgical repair, and when we go back and look at their kidneys down the road, new scars do occur. The final misconception about reflux that I want to share with you is that the pathology seen in reflux is purely infective. That is not the case. It may be developmental. So renal dysplasia may be the cause of abnormality seen on a DMSA scan or an ultrasound, but it should not be confused for renal scarring. So just to reiterate, the kidney is what we're interested in. We want to make sure these kids have good kidney function. And we have to distinguish between dysplasia and versus chronic pyelonephritis. How do we do that? It's very hard. The DMSA scan, and I don't know how available DMSA scanning is available in Egypt. It has been in the United States occasionally difficult to get the radionuclide, but we make it ourselves so we can actually do these studies. But the DMSA scan is probably the most reliable study that will help you determine whether or not the child has renal lesions. If the pattern of uptake of the radionuclide is decreased throughout the whole kidney, one can think that there's most likely dysplasia. However, focal areas of decreased uptake of the radionuclide is more consistent with chronic pyelonephritis. The DMSA scan is also helpful because it may help you determine whether or not you need to do a VCUG. And there's been the approach called a top-down approach that has been favored by some people, where a child comes in with an episode or two of urinary tract infection with fever, and one does a VCUG and sees reflux. The other option is just to go directly to the DMSA scan. If there are lesions seen, then one would go to the VCUG. So that avoids the VCUG in number of kids who don't have lesions and who may not have reflux that may be associated with scarring. And I must admit that I find this approach rather interesting insofar as it will reduce the number of VCUGs, but one may miss some patients who have high-grade reflux. The only way one can determine if these children have renal dysplasia is by doing a histologic analysis. But obviously, we're not going to be doing a biopsy on each and every child who comes in with an episode of pyelonephritis or lesions seen on DMSA scan or an ultrasound. So that is only in special cases that we would do that. However, and we're working on that also at Boston Children's Hospital, we're looking at biomarkers using proteomic techniques to evaluate and measure possible markers of renal damage using a urinary protein profile. And this seems to be fairly advanced at this point. We're hoping that we can have a tool that is quite reliable in determining whether or not children have indeed some degree of renal dysfunction using some of the proteins in the urine. So let's shift gears a little bit, and who should be evaluated for reflux? Obviously, any patient who presents with a prenatal ultrasound showing dilatation of the urinary tract, either SFU grade 3 or upper tract dilatation P3, should most likely undergo a VCUG so as to evaluate for the presence of reflux, especially if there's a family history of reflux. Obviously, any patient who presents with a documented history of febrile urinary tract infection, and so this is a patient who has had possibly admission to the hospital, evidence of pyelonephritis, and this is another patient who should undergo a VCUG. Any patient with bladder anomalies seen on ultrasound, such as diverticular, ureteroceles, duplication of the upper urinary tract, these patients should have a VCUG. And any patient who is suspected to have bladder outlet obstruction or neurogenic bladder, these being patients who have secondary reflux, and will not go into any of the detail about these patients. So how and when to screen for reflux? So an ultrasound is a good screening tool. It tells us a little bit about the kidneys, but I think most importantly, it tells us also about the bladder. Obviously, if there's any bladder wall thickening or any other abnormalities, that's an important thing. The other thing that is also important in my evaluation using the ultrasound is the degree of dilation of the ureters. If the ureters are dilated, I will have a higher suspicion for reflux and will be more inclined to have the patient undergo a VCUG. The voiding cystourethrogram is the gold standard to look at reflux. It is very important to have it done properly with the child as quiet as possible, and make sure that you get voiding studies. At Children's Hospital in Boston, we're trying to do low radiation with minimal amount of radiation in children, and we are able to get fairly good anatomical studies. But in little boys, make sure you look at the urethra, make sure you rule out posterior urethral valves. The radionuclide cystogram used to be a way we followed these patients. In other words, a patient was first seen with a voiding cystourethrogram. We had a good sense of the anatomy, and then follow up a year or year and a half, we would do a radionuclide cystogram. The DMSA scan, I think, is very important in terms of determining what is going on with the kidneys. And in a child who's had several episodes of pyelonephritis, I will always get a DMSA scan because that has prognostic values in terms of how this child will behave with recurrent urinary tract infection. We have not found that MRU is very helpful, although we're developing a software that helps us to ascertain the renal parenchyma, somewhat along the lines of what the DMSA scan can do. But so far, the software has been a little bit difficult to use, and it's extremely time consuming to make the calculation. We're also looking at a new modality, voiding urosonography, where we inject some sonographic material into the bladder. And this, interestingly enough, seems to have a greater sensitivity for identifying reflux as opposed to the voiding cystourethrogram. Obviously, the evaluation must be initiated at the end or shortly after completion of the treatment for the febrile urinary tract infection. If the patient in the hospital, we still feel that it's okay for the VCUG to be carried out as the child is being treated for the pyelonephritis. We don't feel that this will increase the risk for further infection of the kidney. Primary versus secondary VUR, I told you that I would not talk very much about it, but we do have to think about it in terms of obstructive uropathy, especially posturethral valves, neurogenic bladder dysfunction, non-neurogenic bladder dysfunction, bladder exstrophy, and other major anomalies. This is secondary reflux, and one must treat the underlying condition and then address the vesico-ureteral reflux. So for instance, in posturethral valves, don't rush to fix the reflux. That's not the key thing. The key thing is to provide relief of the bladder outlet. I've always been very interested in the grading system. There were a number of grading systems that were developed starting in the 1960s all through the 1973s. None of these systems have really survived the test of time. But in '74 at Boston Children's Hospital, Kolodny and Leibowitz really wanted to have a standardized system. The International Reflux Study also looked for a standardized system. And finally, based on the system that was proposed by Leibowitz, Duckett, and Bellinger, described the international system that we all work with now. In '94, a system was also developed to look at the grading of reflux using a radionuclide cystogram. And I won't go through the details of the grade 1 through 5. You all know this. I'm sure you're very familiar with this. Remember, though, that a VCUG is a test that is done at one point of time and may not reflect what the child voiding behavior is during the daytime or at nighttime. So this is just a very short snapshot in the child's voiding patterns. And there are some significant limitations to the VCUG. There are technical limitations, cooperation, state of hydration. Is it truly a physiologic test? Remember that we're putting catheter in the child's bladder through the urethra, making the child uncomfortable and causing some irritation to the trigone. So this may indeed not be an entirely physiological test. In addition, if the patient has high-grade reflux, the bladder dynamics may be totally changed by that. And we may not be able to get a true bladder capacity in a child who has high-grade, grade 5 reflux when most of the urine is going up into the upper urinary tract. The study may not be easily reproducible. As I mentioned, it's a snapshot in time. The timing of the reflux study can vary also with age and how often to do it. In general, we don't mind doing it in children that are young and do not seem to have too much trouble with the catheter. But as the child gets older, it gets to be much more difficult and much more stressful for the child and may require some medication to quiet down the child during the study. We also feel that the frequency of the study can be variable. I think in a child who's doing very well, doing a VCUG every 18 months is certainly appropriate. If the child is not doing that well, or we have concern with voiding dysfunction, then one may want to do it on a yearly basis. The issue of ureteral duplication is certainly a concern because the grading system is, and I should emphasize that, based on single ureters. So if you have a duplicated system and one has grade 3 and the other one has grade 2, does that really correspond to what we are accustomed to and seen in the single ureters? There's also some interesting studies looking at correlation between radionuclide cystogram grading, and in that regards, the correlation is not that good. I think, as we mentioned with regards to the top-down approach, we should focus on the kidneys when it comes to reflux, and that's where the VCUG can only tell you so much about what's going on in the upper tract. But remember that the behavior of the bladder on the VCUG is extremely important to look at. Make sure you look at the bladder as it fills, look at the bladder in terms of its capacity and its ability to empty. A child who has a high post-void residual may have some voiding dysfunction, and this may play into the recurrence of the urinary tract infection. VUR grading may predict reflux resolution. So we know that there are a number of studies that indicate that grade 1 tends to go away rapidly, grade 2 to 3 also fairly quickly, but grade 4, 5 may not go away that quickly. But that's not 100%, and we knew that the percentages varies depending on the degree of reflux. The grade of reflux may also correlate with renal damage, but that's not also 100%. So the higher grades of reflux may be associated with more renal damage as seen on the DMSA scan. However, the grade of reflux says nothing about the potential for UTIs, hypertension, or the long-term issues of renal failure. Grading of reflux does not tell you about bladder function. You really have to look at the bladder and see how the child behaves as the bladder fills and empties. However, we use the grading system for reflux as our main motivation for treating these patients. And what I would like to leave you with is the notion that the grade of reflux is only one small part of how one evaluates the patient and how one decides to treat the patient and eventually recommend surgery. So please don't rely entirely on the grading of reflux to help you manage these patients. I think that's a very important concept, and I'm certainly happy to discuss this further. So, treatment outcomes for reflux. What are we doing? What are we treating? It's interesting that the Cochrane Review of Diseases, which was published in England, indicated in 2007 that all the treatments that they had reviewed for vesicular ureteral reflux did not seem to indicate that there was a significant advantage for these children to be treated for reflux. So we have not proven to the world that what we do for reflux may actually impact these child in the most positive manner. There's really no outcome measures for reflux that have received a consensus. So we can look at the resolution of reflux, that's very nice, but the child presented with a urinary tract infection. So how are we doing with terms of urinary tract infections once we've treated the reflux? Also, are we preventing renal parenchymal damage? That's another factor that one keeps in mind as one evaluates children with reflux. Are we indeed preventing long-term consequences of reflux nephropathy, such as hypertension or renal failure? And that's very hard to tell because we do not follow these patients for many, many years. I think some of the patients that I see, once the reflux is either treated or they've outgrown their reflux, we don't see them again, but they may have renal damage. And this is reflected in a few long-term studies over 10 years that have looked at the outcomes, either single outcomes or grouped outcomes, and there is still quite a bit of uncertainty. The studies that are coming out of Sweden are certainly showing some good insight as to how these children do in the long term. However, we still rely on these tools of VCUG RNC and DMSA scan to look at the outcomes for these children. How many of you do a VCUG after you've operated on a child for vesicoureteral reflux? Does anybody do a VCUG to check on the results of their surgery after a surgery for vesicoureteral reflux?
Unless the child is symptomatic, unless he's developing frequent UTIs, you don't do a VCUG.
I think that's a very good approach, and I totally agree with that. It's been shown. I will tell you that half of my colleagues at Boston Children's Hospital still do a VCUG because they want to be sure that the reflux is gone. But we should rely on our surgery, which is quite reliable, 95% success rate, and trust that we're doing a good job at fixing the reflux. So what are the, sorry about that, skipping around. What are the treatment options for vesicoureteral reflux? Obviously, the treatment is either surgical or medical. The medical management is based on the fact that most of these patients will outgrow their reflux. So if we can keep them infection-free until their reflux is gone, then they will do fine. And most of these children who have low-grade reflux tend to do well. We know that from studies done in the 70s that antibiotic prophylaxis works pretty well. And this has been confirmed more recently, especially with the RIVER study, and we'll talk a little more about that in the next slides. At this point, I think most of the patients grade 1 through 3 should be treated with antibiotic prophylaxis unless they develop breakthrough infections. And I think these patients do very well so long as they are compliant with the medication. So just a rapid review of the RIVER study. Antimicrobial prophylaxis reduced by half the risk of urinary tract infection recurrence in children with vesicoureteral reflux, so that's a significant number. But it had most benefits, and this is something that we should all keep in mind, that if patients who had bladder and bowel dysfunction and these issues were treated in the face of antibiotic prophylaxis, these patients did much better and had a low rate of urinary tract infection. So always investigate these children for the potential for constipation or difficulties with urination. There was no difference in the degree of scarring in patients in the study, but this was a fairly short follow-up for these patients. The problem with antibiotic prophylaxis is that obviously it will select out bacteria that may be more difficult and resistant to antibiotics, although I must admit that in my experience, that's actually quite unusual. So the bottom line here is antibiotic prophylaxis works, but it doesn't reduce the rate of renal scarring. So let's switch gear a little bit and talk about surgical treatment for vesicoureteral reflux. And these are usually my criteria for treatment of reflux using surgery. Patients who have breakthrough urinary tract infection while on antibiotic prophylaxis, patients who have reflux that does not resolve after years of surveillance, and if the parents want to proceed with surgery. And I will go into a little more detail by saying that if a child is 5 years old, has grade 2 to 3 reflux, has had no infection, has been off antibiotics, and as well, I usually don't recommend any surgery. I will usually recommend surgery in children who have grade 4 or 5 reflux, even though they may not have infections, if indeed the reflux has not evolved positively. Obviously, if patients are not taking their medication and had recurrent urinary tract infection, we'll be concerned about the fact that they may be at higher risk for pyelonephritis, and therefore we will usually suggest surgery. High-grade reflux is also a situation where the spontaneous resolution is low, and we may want to take care of the problem. I do have a small group of patients who are male, who have high-grade reflux, who have not been operated on, and some of them have developed some voiding dysfunction because of the yo-yo effect of the urine going up and down and making the bladder not function properly. And these kids had urinary tract infection, and they benefited greatly from surgical reimplantation. We also get concerned about patients who maybe in the face of a recurrent urinary tract infection develop new renal scarring, and in these patients, we usually suggest doing surgery. So the surgical options for the management of reflux are the endoscopic injection of a bulking agent. It's an outpatient procedure. Success rate is 70 to 80%. It can be repeated, but the long-term data is lacking. I must admit that I was a big proponent of endoscopic treatment of reflux in the 1990s, 2000. I did a fair amount of research on that. I was started on the path of studying endoscopic treatment by Dr. Jeffs in Baltimore, and we studied collagen, and then we studied autologous collagen, and all these procedures seem to have fairly good short-term results, but the long-term effects were not all that great. And I have to say that I now select out my patients a lot more in terms of suggesting endoscopic treatment. I usually reserve it for grade 2 to 3 reflux and parents who don't want to have antibiotics on board anymore, and parents who want to move on. That being said, we've seen a number of cases of young adults who've been evaluated in the emergency rooms. They had forgotten that they had endoscopic treatment of reflux. They were found to have calcifications at the end of the ureters and felt to possibly have a stone, and they were evaluated for possible stones when indeed the deflux or whatever material was injected had calcified, and that caused them to undergo uteroscopy for unnecessary reasons. The open surgical repair is really the gold standard. It's time tested. It had good resolution rate, 95 to 98%. And it has a low complication rate if it's done by someone who has good experience and has been well trained. And I must admit that I find the Cohen technique to work very nicely. If it's unilateral reflux, we'll tend to do an extravesical reimplantation, and the patients just stay in overnight and then go home the next day. Same thing with the open surgical procedure. If it's bilateral, they come in the morning, go home in the afternoon the next day, and they seem to do quite well. We have done some of these cases using a robot, but we don't find that the robot has that much of an advantage over the open procedure. I think a small fan and steel incision works very well. It's effective, and I think the patients recover just as quickly. The surgical treatment has been shown to reduce the rate of pyelonephritis, so there is some advantage to that, but it's really less clear as to whether or not open surgical reimplantation of the ureters has reduced the rate of renal parenchymal damage. So to bring this talk to a conclusion, I thought I would offer a case that illustrates some of the points that we discussed today. And this is a case of a 4-year-old little girl who was toilet trained. She has had several febrile urinary tract infection, one of which had her in the hospital on IV antibiotics for a few days. She was evaluated with an ultrasound showing left lower pole parenchymal thinning, and she underwent a VCUG and a DMSA scan. So I'll show you her evaluation, and then maybe you can pipe in and tell me what you think you'd like to do for this little girl. So this is her VCUG. Here's her bladder, and she has probably grade 3 on the right-hand side, and on the left side she has a duplicated system, right? And it's probably a full duplication all the way down, although it's not completely clear. It may be a Y duplication. And this was what she has after she urinates. Would anybody care to comment about the VCG at this point?
She has significant post-voiding urine volume. That's what is
Yeah,
apparent.
very good point.
Mm.
So she has a fairly large bladder, doesn't she? So
Yeah.
that's a little bit of a concern. She may have some voiding dysfunction. And then if you look at her VCUG after she's urinated, she also has a lot of urine there. So this is certainly a predisposing factor for her to get urinary tract infection. Her voiding dysfunction may be an issue. I also look on the VCUG for any evidence of accumulated feces and to look for constipation. In her case, I don't think she has a lot of constipation, but that's certainly something you want to investigate. As we know that constipation may be a predisposing factor to urinary tract infection. So first off, in this child, as you rightly pointed out, we may want to put her on a voiding schedule, and we want to maybe have her do double voiding so that she empties her bladder properly. Okay? Any other points about this?
I think this VCUG is missing the early filling phase.
Yeah, I wanted to simplify it and make it quick, but the filling phase looked pretty normal and the bladder is nice and smooth.
Okay.
Yeah, the other thing that you might see here a little bit is maybe a little intrarenal reflux, but that's a little detail that may not be of importance. So let me show you her DMSA scan here. This is your DMSA scan, and what we see here is a fairly healthy kidney on the right, not a lot of issues. And then on the left, we see a kidney that has good amount of parenchyma in the upper pole, but the lower pole is abnormal.
Yeah.
So would you say that this is due to infection or is this due to renal maldevelopment?
How can we know? Well, how can we know that if we don't have a baseline DMSA scan for this girl?
So this is her baseline. She came in afterwards and she's 4 years old. There's no way of knowing. All I can tell you is that she had an ultrasound prenatally, and both kidneys were identified at 36 weeks of gestation. And the left kidney was felt to be smaller than the right kidney.
Yeah, but the irregularity and the thinning of the cortex on the lower pole of the kidney might be due to recurrent infections, or might be something that is a congenital dysplasia, for example.
Absolutely. So it could be a combination of both.
Yeah.
We don't really know. There was most likely some degree of dysplasia since the kidney was noted to be smaller on ultrasound, on the prenatal ultrasound, but she may have had episodes of pyelonephritis, and this may have made the situation worse. So totally agree with you. Your assessment is appropriate. It could be both. It could be renal dysplasia, and it could be recurrent pyelonephritis. So how would people approach this? Let's poll the audience and tell me how you would counsel the parents.
Well, you have to manage the reflux on both sides, because even if it's a low-grade reflux on the right side. But if you're gonna interfere, I think you have to manage both sides. So if you're gonna go for a uretrovascular implantation, you're gonna do a common cheese on the left side and a right side uretrovascular implant. If you're going to do something intravesical.
I would agree with that. I would agree with that. Would anybody consider putting her on antibiotics and watching her for a year with some behavioral modification, maybe some constipation treatment?
For sure, I have
You just said you have to treat her, with time voiding. You have to put her on behavioral therapy, and first of all, and to decrease this post-voiding urine volume. This is the most important thing first. And if reflux persists on both sides, so I guess you have to go for surgery.
I think that would be my approach. I think I would keep her on antibiotics for a year, see how she does, make sure she gets some urotherapy, and then repeat the study. And repeat the VCUG and see where we stand with the reflux. Say for the sake of discussion that the reflux is the same grade, there's been no change, she is emptying her bladder and her post-void residual is 0. And in the meantime, she's not had any urinary tract infection. What would be your approach? She's now 5 years old.
If she is not having any urinary tract infection and she is voiding very well with no significant residual, and the ultrasound follow-up is good, why I intervene? I can continue follow-up if parents agree to continue follow-up. The compliance of family at that point is very important.
Absolutely, absolutely. So I think I would give the parents the choice of fixing a reflux. I would not insist upon it. I would say that she could do fine. And I think I would probably try her off antibiotics to see how she does. If she does get an infection while off antibiotics, then I think at that point I would suggest surgery to fix it. Would anybody consider endoscopic treatment for this case?
Yes.
I wouldn't go for endoscopic treatment, no.
Why not?
Because you have to inject the 3 ureters. You have to inject the right side and you have to inject the upper and lower moiety. And I don't think injection in duplex system gets good results.
I think you're absolutely correct. My experience with duplicated system has not been very good. And I think the endoscopic treatment in this case would probably not have the outcomes that one would want in terms of reflux resolution. So
but Mark, please, do you mean the results of the endoscopic treatment in duplication without urethroseal are bad as the results of endoscopic treatment in patients with duplication with urethroseal, or it is completely different?
Well, I think it's very different. I think if you compare single system endoscopic treatment to duplicated system, our results are not quite as good. There are some articles in the literature to suggest that they're equal. That has not been my experience at all.
Yeah, and also, Mark, I could consider this a child in the presence of this scarring or dysplasia or the combination, a high-risk case of VUR. So I will choose surgery for that reason more than the other reason.
I certainly would agree with that. I certainly would agree with that. And remember that her grade of reflux to the lower pole of the left kidney was, grade 3 to 4. So the chance of that reflux going away is not very good. In addition,
that's why I wonder why.
Yeah. In addition, the intramural tunnel on the left side was going to be probably fairly short. I think it's an ectopic ureter, more cephalide than anything else, and therefore you're not going to have a lot of space to inject material in there.
Sir, that's why I wondered why you can offer her if the voiding dysfunction disappeared and reflux persists after a year of treatment. I wouldn't think of putting her on conservative treatment. She's a female, she's 5 years old, she has bilateral reflux with high-grade reflux on the left side, she has a duplex system. Spontaneous solution, I don't think it can happen, and even if it happened on one side, it will not happen on the other side on this duplicate system.
So
the possibility of problems later on with the pregnancy and with adolescence, it will cause more problems.
Well, I'm happy you brought that up, because you see, it all depends on how you look at this. Do you look at this as treating the reflux and getting the reflux out of the picture?
No.
Or do you look at this in terms of voiding dysfunction? Or do you look at this in terms of preventing urinary tract infection? So there are several things that have to come into your decision-making process that will make you decide how you want to counsel the parents and how you want to help the parents. So we all have a little bit of a bias. We kind of know what we want to do. We are surgeons. We like to fix things, and we have a very good tool to fix reflux. It's reliable, good results, but I think what you bring up is a very good point. this child could get into trouble down the road, could potentially get into urinary tract infection if you don't treat the reflux. So that's certainly something that you want to discuss with the parents and explain to them and make them part of the decision-making process insofar as they can be made aware of all the potential issues. It's not just the reflux. It's the urinary tract infection. It's the voiding dysfunction. It's the duplicated system. Now, you as a physician, as a surgeon, are there to guide them and to make the recommendations that you think are the most appropriate. But I think it's important to keep all this in mind when you look at reflux. And I'm very happy that you bring out these various points, because that's the point of my discussion.
Yeah, Mark, did you finish the presentation or still?
No, I have a few more things. So I'm just going to summarize. Obviously, there are some clinical factors that are important in the treatment and management of reflux. Obviously, the presentation. Think about the classification of reflux that we talked about at the beginning. The age of presentation. Right now, I have a 16-year-old young man who has vesicoureteral reflux on one side, and he's getting recurrent episode of pyelonephritis. So he's much older. He's atypical, and he's getting into trouble for infection. The male factor in his case is also interesting. This is unusual. You don't see young men getting urinary tract infection. Obviously, gender is important, male or female. The history of urinary tract infection, the findings on VCUG, and I'm very happy that you described what the concerns were in that particular case that we talked about. Talking about elimination habits, difficulties urinating, constipation, the status of the kidney, and then what we have as our personal biases. With that, I think we should consider a comprehensive approach to reflux. We will have better tools to select these patients out, genetic criteria, better evaluation of the kidneys, and possibly some new diagnostic modalities. But I think individual risk assessment based on UTI susceptibility, biomarkers of injury, and bacterial virulence will also be important to look at as we move forward in the evaluation of reflux. And I think we'll less and less rely on radiation-inducing technology, and we'll look at the outcomes a little bit better. With that, I want to thank you. Shukran to all of you for taking the time and spending a little of our evening talking about vesicoureteral reflux. I'm currently on Cape Cod beside the beach, but I'm inside the house. And I hope that Ramadan is going well for everybody and that you are able to avoid this COVID-19 epidemic. But thank you again for inviting me. It was really enjoyable to reconnect with my Egyptian friends.
Thank you, Mark. Very, very illustrative presentation and very interesting presentation. And of course, you know, interesting presentations stimulate people to ask more interesting questions. And
yes.
So we have two pediatric urologists who are very, very enthusiastic of vesicoureteral reflux with you, Dr. Shuman and Dr. Sak. We'll ask you the different questions people chatted with us. Thank you. Thank you, Mark.
You're welcome.
Thank you. Thank you, Mark. Thank you, Mark, for this your presentations, which is very illustrative for us. And for sure, I have to take the advantage of this opportunity and discuss with you some points first for my audience.
Sure.
My first question is about how can we risk stratify our patient with vesicoureteric reflux? But I think it's more complex than the grade of the vesicoureteric reflux.
That's correct. I think that's a very, very good question. About 10 years ago, I tried to put together a VUR score based on various factors that we discussed. And unfortunately, we had a lot of trouble validating this score using patient-based studies. I think Chris Cooper in the United States has also tried to look at some risk assessment. I think Tony Caldemone has also looked at this. And I think the risk stratification is something that we need to keep working on and include a number of factors. These factors are bladder behavior, appearance of the kidneys, age of the patient, presentation. I think prenatal versus postnatal is important, and the presence of urinary tract infection. So I think when you see a patient and you evaluate them and you know what the grade of reflux, then you have to plug in the other variables that we discussed. And that's how you can grossly stratify the risk of the patient. It's clear to me that a patient who's got fairly high grade reflux, has renal parenchymal lesions on DMSA scan, and who has voiding dysfunction is at much higher risk for further episodes of pyelonephritis. And what I really want to do is to prevent pyelonephritis. That's my goal in this patient. And so I will do everything to mitigate the risk of pyelonephritis based on this gross risk stratification.
Thank you. This takes me to the term of psychoretic reflux index, which was published by the group from Atlanta and published in Journal of Urology. Do you think this is a validated index that we can use to predict the resolution of the psychoretic reflux?
It's not well validated, and it needs to be done in a larger population. I think we need to talk about a cohort of several thousand patients to be able to validate that index. I think it's a good effort in the right direction, but I don't think it's well validated yet.
Okay. My second question is, does in reality, do we have these two entities of VUR, the symptom and the disease?
That's a good question. I mean, obviously, the manifestations of the condition are varied. Hydronephrosis is one of the manifestations. Infection is another manifestation. But remember that infection and vesicoureteral reflux are only linked in their association. One is not the cause and effect. So I think, to me, vesicoureteral reflux is a symptoms of other things happening. In other words, high-grade reflux, you may have some renal parenchymal damage, you may have some bladder dysfunction, and you have a low resolution rate. So I think you have to put the whole thing in context.
Okay, my last question is, how does VUR resolution take place? Is it a matter of anatomical maturation and or change in the bladder dynamics?
That's an excellent question. I thought about that a great deal, and I think it's a combination of both. The bladder dynamics are such that if you voided high pressure, the pressure has to be vented either via the urethra or up the ureters. If there is a partially competent valve mechanism at the level of the uretrovesical junction, that valve mechanism will not sustain the high pressure, and then that will cause the reflux to occur, especially in those patients who have either voiding dysfunction or secondary reflux. There is also an anatomic component to reflux, and that is the fact that and that was demonstrated by Paquin in the 50s, if there is a shortened intramural tunnel, that valve mechanism will not be competent at a certain level. But I think it's all dependent on the bladder dynamics. So it's the interaction of the bladder dynamics and the anatomical organization of the ureter with the bladder.
Okay, I will shift now to Dr. Ahmed Shuman and see you later.
Thank you. Thank you. Thank you for the good questions.
Well, thank you, Dr. Marc. This brings me to a question in continuity with Dr. Ahmed Saar's question. Would you consider giving anticholinergics and alpha blockers for infants with reflux, with primary reflux? Put in mind that the bladder dysfunction is common in these children?
So I think that's something I've never thought about. So that's a good thing for me to think about. I would be reluctant to put a child on anticholinergic medications if he is very young in the face of high-grade reflux because of the potential toxicity of the anticholinergics. I'm not sure that this would improve the dynamics to the extent that one would see the reflux go away. I think in the little boys who have high-grade reflux, there is a definite anatomic defect. If you look in via cystoscopy, these patients all have a fairly large, wide open ureteral opening with basically no intramural tunnel. So I think at this point, the anticholinergics are not something that I would recommend in this situation. I think there's an anatomic defect that ultimately may improve, but most likely will not.
Another question I have, I got a little bit confused about the relation between reflux and UTI.
Yes.
Is there a correlation and increased incidence of UTI with reflux, or there is no increased incidence of UTI with reflux? And this brings me to the value of continuous antibiotic prophylaxis. If there is no increased incidence, so why are we giving continuous antibiotic prophylaxis?
It is to prevent infections. It's not that there is a higher risk of urinary tract infection. It's just to prevent infections in the first place.
But
Okay.
but children with VUR, they have higher incidence of UTIs than other children.
Well, we don't know that. We don't know that because we don't know how many children have vesicoureteral reflux. We only know about the children who present with urinary tract infection and who get evaluated and are found to have vesicoureteral reflux. There may be a lot of children who have reflux who never get urinary tract infection, and we never evaluate them, so we don't know whether or not they have reflux.
Okay. Fine. I'm going to ask you some questions from the audience. First question is siblings screening for reflux. You said that you're not anymore for screening siblings.
Correct. So the reason for that is that studies that were done by Jean Hallowell about 10 or 15 years ago seemed to indicate that children who were screened, siblings who were screened for reflux, did not seem to get into trouble with urinary tract infection and had a very low incidence of renal parenchymal damage. So in that particular situation, it was felt that siblings with reflux did not have vesicoureteral reflux that put them at risk for pyelonephritis and for further infections or for renal damage. And therefore, it was felt that screening was not important. We, I think, are interested in those patients who get urinary tract infections and pyelonephritis because those are the kids who can get into trouble down the road. So the sibling reflux is certainly a condition, but it's not a condition that seems to be associated with a lot of pathology.
Okay. Another question regarding the high-grade reflux.
Yeah.
What about high-grade reflux and bladder dysfunction? Would it cause bladder dysfunction or vice versa, or the bladder dysfunction that caused the high-grade reflux?
So that's actually an excellent question. I think there are two situations where you will have high-grade reflux. One is a congenital anomaly, probably Kekat, where the ureter has not inserted properly in the bladder because of abnormal ureteral bud development. And you get high-grade reflux due to the fact that the insertion of the ureter is abnormal with no valve mechanism. That, over time, in a little boy, may lead to bladder dysfunction because of the fact that the bladder never empties. In other words, every time the bladder fills up, bladder then squeezes down, and then a lot of urine goes up into the upper urinary tract, and some of it goes down through the urethra. So this sort of abnormal cycling makes the bladder work more frequently because the bladder is actually working over time to try to empty, and the efficiency of the emptying is not happening. In other words, the bladder just can't empty completely, and the bladder becomes abnormal. And this is usually seen with children who have had high-grade reflux for years, 4, 5, 6 years. And you'll see that on ultrasound, they have a fairly thickened bladder wall, and their bladder is never, never empty. The other situation, and that's where you have high-grade reflux in the face of bladder outlet obstruction due to spina bifida, or neurogenic bladder of some nature, with urethral valves, where in fact the bladder pressure is generated by the fact that the bladder is not emptying properly because of the anatomical obstacle, and that causes the reflux to occur because the bladder has to have a pop-off mechanism. And so in these patients, when they are not able to empty their bladder properly because of posterior urethral valves or incompetent sphincter mechanism, then that is a situation where the reflux will only get worse because of the high pressures generated by the bladder.
Shuman, can I ask a question, please, Shuman?
Yes, sure.
Mark, please, if you have a child with an antenatal diagnosis of hydronephrosis, and
Yes.
in the postnatal period, due to the SFU grade 3 or 4, you did VUR and proved to have bilateral primary high-grade vesiculotoric reflux.
Yes.
He is a male, okay? So will you suggest to the parents to do circumcision or not? And you are going to put him on antibiotic prophylaxis. This is the way. Until when you are going to keep the prophylaxis? And at time of you are going to stop the prophylaxis, will you do VUR or not if the child is asymptomatic?
Okay, so here's how I would approach this young child. Obviously, we get an ultrasound postnatally. We get a VCUG, and he has high-grade reflux. I would definitely put him on antibiotic prophylaxis. I would definitely recommend circumcision. And bear in mind that the circumcision has protective effects for the first 6 months of life, but that's the most critical period of time, because obviously a child who is 3 months old who gets pyelonephritis can get terribly sick and can get really into big trouble. And so I would put him on antibiotic prophylaxis. I would then monitor him with an ultrasound at 6 months of age to see what the kidneys look like, make sure the kidneys are growing properly. If I see that the kidneys are not growing properly, then I may consider getting a DMSA scan. And then I will see him back at 1 year of age with a repeat VCUG and an ultrasound. If there's persistent high-grade reflux, I will continue antibiotic prophylaxis. And if there is evidence of renal damage, I may consider suggesting surgery, although I don't have a very good reason to do that. But it's more in terms of preventing bladder dysfunction than preventing pyelonephritis. One thing that we don't do very well, and I didn't talk to you about that during my talk, is the fact that I think some patients are more prone to urinary tract infections than others. And so it's a little bit of a dilemma as to what to do with a patient who is totally asymptomatic, has reflux, never has had a urinary tract infection. That is a little bit of a dilemma. And I know there was a discussion recently with Marty Coyle, Tony Caldamone, and Andy Kirsch about this. But I think that's an area of controversy, and it's really a matter of deciding with the parents what they feel most comfortable with. But that would be
So Mark, please, as long as you are going to keep the antibiotic prophylaxis, if the DMSA scan is good,
yes.
why you repeat the voiding cystohystogram?
Well, I'd like to be able to see what the bladder is doing, and I want to see what the bladder dynamics are. I think it's important to know whether or not this child is emptying his bladder properly, and I want to see the degree of reflux. If the degree of reflux is improving, it's certainly a very encouraging thing. If I see persistent high-grade reflux, then I get worried, and I'm concerned about the potential for either infection or bladder dysfunction. So I think that has prognostic value, and I think the VCUG is important in that regard.
My last question, I will leave Shuman. What is your experience in the bilateral extravesical reimplantation on the consequences of voiding dysfunction?
So it's interesting. I'm quite conservative with my surgical approach. In other words, I want to minimize any risk. And so I think you can get away with a good extravesical reimplantation if your dissection is not super extensive on either side. But I will tell you that you have the risk of urinary retention in about 10 to 20% of patients. And I think that is too high risk for me to consider doing bilateral extravesical reimplantation. One of my colleagues does it, and I think you can get away with it sometime, but to put a child in retention and then having to go back and put a catheter in and all that, it's not worth my while. It really isn't. I have a good intravesical operation that works nicely. I'm not going to risk it. That being said, I think it's a marvelous operation if you have unilateral reflux.
Yeah, thank you. Shuman?
Okay, let's resume these questions from the audience. What's your approach for investigating a case of reflux? It's always a top-down approach, or if you're doing a bottom-up approach?
No, I do the top-down approach in parents who are very reluctant to have a VCUG. I still like to know, I find a VCUG has the value that we talked about, you know, good anatomic evaluation of the bladder and the upper urinary tract. But if the parents are really opposed to having the catheterization, then I think the top-down approach is perfectly reasonable. I would say that I probably do the top-down approach in about 20% of my cases.
And what's the timing of the DMSA scan? When do you do the DMSA?
That is an excellent question. It's really quite controversial. Obviously, if you have pyelonephritis, you may see some changes in the kidney, and these changes may be temporary. So I think if I see a child who's had an episode of pyelonephritis, the parents do not want to do a VCUG, and I want to know more in terms of, did the child actually have pyelonephritis and were the kidneys involved? I will suggest doing the DMSA scan within the first month of the pyelonephritis. Then I may consider repeating the DMSA scan 6 months to a year down the road to see if these changes are permanent. If there's indeed renal scarring, then that makes it a little more concerning to me, because as you know, patients who have renal scarring tend to be more prone to recurrent urinary tract infection and episodes of pyelonephritis, as demonstrated by Baskin and colleagues in San Francisco.
And would you think that even if these scars that were present early after 2 weeks of infection resolved 6 months later, do you think that this child is not prone to more risk of deterioration or developing renal damage? So
I'm concerned about anything that I see if there is a DMSA scan change. In other words, if there's evidence of decreased uptake, I'm concerned that this child is more prone to potential urinary tract infection / pyelonephritis down the road. So yes, it's a concern. If the kidneys are completely healthy, even though the child has had an episode of pyelonephritis, then I'm happy with that. That's good news. Prognostically, that's good. But if there's any evidence of renal involvement, that tells me that the child is more prone to potential upper tract infections.
Mm-hmm. Okay. So another question, a male child who's 9 months and he has a bilateral grade 5 reflux.
Yeah.
How would you approach this child?
I think it's pretty much along the lines of what Haitham described. And that's, I would probably repeat the VCUG sometime a year after the initial diagnosis. Has the child had a urinary tract infection?
This is the question. This is only the question that I received.
So just grade.
No pyelonephritis and UTI.
High grade bilateral reflux for a 9 months old child. For a 9 months child.
Yeah. So I assume he was circumcised.
Probably right? He's circumcised, yes, because we do circumcision routinely here.
Yes. Yes. Yeah. So I would definitely put him on anaphylaxis. And then I would monitor him closely with a repeat ultrasound 3 to 6 months down the road to see how he's doing, and then repeat the VCUG a year down the road. If he does develop a urinary tract infection, then I would suggest surgery.
Well, do you think the spontaneous resolution of this child with bilateral grade 5 reflux?
Low potential, but still possible. I've seen this in a number of cases.
You just counsel his parents about this? that probably he might need surgery.
Yeah, the parents would definitely be counseled that he may need surgery down the road.
Okay, good. So a question, I have a question. Would you consider children with the BBD having primary reflux or second reflux?
I'm sorry, can you repeat the question?
Children with bowel and bladder dysfunction. Children with bowel and bladder dysfunction and reflux. You consider these children as a primary reflux or a second reflux, or it's a different entity?
So I think that goes back to our discussion of the dynamics of the bladder and of the ureterovesical junction. So I think in this particular situation, I think they probably have a propensity for reflux, but it can be considered secondary because of their bladder dysfunction.
So you mean that their ureterovesical junction is a borderline, and if anything happened to ureterovesical junction, that's borderline junction?
So their bladder dysfunction is actually causing the reflux. They are holding the urine, they're voiding at high pressure, they have a partially incompetent ureterovesical junction, and this is what's allowing the reflux to occur when their bladder is not working properly. So once you fix, and that's been shown quite convincingly, once you fix the bladder dysfunction, these patients tend to outgrow their reflux much quicker. But these are patients in whom I don't usually use anticholinergics because I'm concerned that it's going to make their constipation worse. In other words, I really rely on behavioral techniques, biofeedback, and anything I can do to get them through to the point where their bladder function is restored without any medication. But they may stay on antibiotic prophylaxis during that time.
So another question, how do you tell the parents when they ask you about the continuous antibiotic prophylaxis and the risks of developing problems from it? How would you tell the parents that about this? Yeah,
that's a very good question, because we see this quite a great deal, and I'm sure you do too. Parents are reluctant to put their children on antibiotics, and one way I explain to them is that, first of all, the child is not going to be exposed to the antibiotic 24 hours a day. The child is exposed to the antibiotics for maybe 6 to 8 hours during the time the antibiotic is in the system. And I tend to use either trimethoprim sulfa or nitrofurantoin, which are concentrated in the urine. And so they're absorbed by the intestinal tract. They're then gone through the bloodstream and then concentrated in the kidneys and then into the urine. And usually this is a short period of time to which the child is exposed to the antibiotics, not 24 hours a day. In addition, I asked the parents to put the patient on some type of probiotics, either yogurt or commercially available probiotics, and that should protect them from any type of other bad bacteria. I do explain to them that there's a small chance that a resistant organism might develop, but I think the likelihood of that happening is actually quite small. And the RIVER study looked at that, and they did not seem to think that there was a high incidence of antibiotic-resistant bacteria that occurred in patients who are on antibiotic prophylaxis. I think there are other risks associated with antibiotic prophylaxis. Some of them are just regular allergic reactions. We always have to be concerned about things like Stevens-Johnson when we use trimethoprim sulfa. There are certainly some concerns about that. But in my few years of practice, up to 30 years, I have not seen a lot of trouble with antibiotic prophylaxis.
And will you keep the prophylaxis till 2 years of age or till 5 years of age? Usually
until toilet training. Once the child is shown to be toilet trained and doing well with toilet training, that's usually when I'll stop. The highest incidence of urinary tract infections in little girls is usually during toilet training. So once a child is shown to be toilet trained properly, then I think it's appropriate to stop the antibiotic prophylaxis.
Shuman, Mark, please. When the child is toilet trained and you are going to stop the antibiotic prophylaxis, there are two schools. There are two schools for discussion here. just to stop the antibiotic prophylaxis and to see whether the child is getting infection or not. And if he's getting infection, you repeat the VCG. And the other school is just to stop the antibiotic prophylaxis after doing the voiding cystohistogram and being sure that reflux no more present. What school you adopt?
So I will usually have the child come back after toilet training. And I do this a little differently. If the VCUG shows relatively low-grade reflux, and the parents are comfortable with this, I'll make sure that the child is on a strict voiding schedule, make sure that the child goes every 2 to 3 hours, empties his or her bladder properly with double voiding. And then I will put the child on antibiotic prophylaxis every other day for a month to see how the child does. It's kind of a taper of antibiotics so that the child is still covered every other day. And then I will stop completely and not repeat the VCUG unless the child develops a febrile urinary tract infection. I will get an ultrasound a year after the last VCUG to monitor growth of the kidneys, monitor bladder, make sure it's a bladder and kidney ultrasound to look at the bladder dynamics, make sure the bladder is emptying properly, looking at bladder wall thickness, and looking for any anatomical abnormalities, maybe some constipation. You can see if there's accumulated feces in back of the bladder on the ultrasound. So the ultrasound is very helpful for me to get sort of a state of the child from a purely general standpoint. It's not going to tell me anything about the reflux, but at least I'll know whether or not the child's voiding properly, is not constipated, and the kidneys are growing.
Thank you.
Mark.
Yes.
I am Ahmed Sar again.
Yes.
Do you think that the pendulum is moving now from the surgery side to the more conservation with or without cap?
I think you're right. I think people are moving away. If I look at my practice, I started practice in 1990. I was doing about 100 cases of vesicoureteral reflux a year, and now probably 20 to 30 a year. And I've slowed down a little bit, but there's been a big shift in the number of cases that we do. Absolutely. I think we are selecting our patients much better. And I think we're doing a better job at deciding who really needs the surgery. It's not perfect, but I think we're doing a better job at that.
I have another question. Sometimes after a successful surgery, we found a persistent UTI post-operative, and in another situations, we could face with a contralateral VUR.
Yeah, so recurrent urinary tract infection in these children can be pretty tricky. Obviously, you want to make sure that there's no voiding dysfunction. You want to make sure that there is no anatomic reason where the reflux is occurring. These are children in whom I might consider keeping on antibiotic prophylaxis for a while. It's rare, but some of these children just have a bad anatomy and they don't do well, and they may require long-term antibiotics. In terms of the contralateral reflux, that happens less than 5% of cases, and obviously it's a matter of how bad the reflux is. And I think, to me, it's usually a reflection of the fact that there probably is some underlying voiding dysfunction that has to be evaluated and worked on. Some of these children may require evaluation using a urodynamic study to see what their bladder pressures are, because if indeed you have new onset reflux on the other side, you have to suspect that they're probably having some fairly high pressure voiding, and that may predispose them to that contralateral reflux. I wouldn't worry too much if it was reflux grade 2 to 3. But if it was high-grade reflux, then that would be a definite concern.
Yeah, Mark, discussion with you is very interesting. It is endless. We are honored to have you with us today. We have 100 participants during the 1 hour and 30 minutes past. They are refusing to go away. They need to stay with you more, but we don't want to be more silly and and making more questions for you. Of course, we will meet you in another meeting or another lecture again. We will be delighted and honored. And again, on behalf of the Egyptian Pediatric Urology Club Group, I am thanking you very much for accepting our invitation and for your presence with us and your patience for our questions.
It's my pleasure, my honor, and I really enjoyed this whole discussion. I think it's a very, very interesting topic, and I appreciate you asking me to talk about it. Be more than happy to speak with you again very soon, and I wish you all the very best, and go and enjoy your family now.
Thank you, Mark.
Shukran.
Very nice to see you. See you again.
Okay, bye-bye.